All right. So when you think about a 12 lead, I would look at this one. I say, is the rate too fast, too slow, or okay? Rate looks good to me, right? So the rate's more than 50, less than 140. Rate is okay-ish. The next thing I want to do is look at injury patterns because we can fix STEMIs now, right? So I look at leads 1, AVL, and 5 and 6. These are my lateral leads. I'm looking for ST elevation. If I got 2 leads in one of those 4, I got some good feedback here, Chief. Yeah, on my computer. How about now? I still got feedback. Is it messing you up? Okay, I'm hearing echo. That's great. Thanks for smiling. Sweet. So 2 leads with ST elevation, 1 AVL or 5 and 6 concerning for a big STEMI, right? So I'll look laterally first. Next place I'll look is 2, 3, and AVF. These are my inferior leads. So if I get elevation any 2 of these, this is a big STEMI. I'm done. I know the patient's having a big, massive MI. I manage the patient. I start moving toward a hospital that can take care of this guy either by cath lab or thrombolytics. Next place I look is V1 through V4. So elevation in any of these is very concerning for a STEMI. And then if you look at the V2, V3, and V4, you got ST depression, T-wave inversion, that's a posterior. Remember, V1 through V4 is the front part of the heart. So if you're depressed, it's the back part of the heart, right? So this is old school. When you printed one out, it was thin paper. You'd flip it over and look at it for ST elevation. You don't have to do that anymore, okay? Depression there is a STEMI. Last place I look is lead AVR. So for years we said if you're up in lead 1 and down in AVR, your leads were on correctly. And that's all we really looked at. However, in 2013, American Heart came out and said, actually, if you're up in AVR and you have ST depression anywhere else. So if I'm up in AVR and I got depression in 2, 3, AVF or laterally, that's concern for a big left main occlusion. So that's a STEMI equivalent. That person should be seeing a cardiologist. Now, sometimes old folks will get up in AVR and have some depression when they're tired, they're hypotensive, tachycardic, but that's not a decision I'm going to make. I'm going to be on the phone with the cards, talking to them, let them make that decision do they go to the cath lab or not. So 12 leads are kind of daunting when you look at them, but in reality, it's fairly simple to pick out sick or not sick. All right, we don't have to be super fancy with this. This is a cool diagram I got off the interweb that kind of shows you lateral 1 AVL, 5 and 6, 2, 3, and AVF is your inferior coming off the right coronary, and then AVR, septal and anterior. Any questions within reason so far? All right, I like this. Thank you. Sweet. So again, I think that EMS providers, medics should better pick up STEMIs. Okay, and the reason I say this machine is not correct. If you talk to the manufacturer of LifePak or Zoll, these folks, they'll say about 93% accurate. I would argue probably not. I don't trust the machines. You got to have that human factor. What's wrong with this monitor right here? What do you see wrong with that one? Blood pressure. Yeah, that don't make sense, does it? Yeah, sweet. So again, I recommend you that you guys learn 12 leads, understand them, and can make a big difference in your patient, okay? Determine whether you stand on scene a long time, which hospital you go to, if you have a choice in hospital destination, but nothing else, it gives the hospital a pre-arrival notice that, hey, I got a STEMI, just get ready. That way we got our 30 minutes, 60 minutes to get them prepared to get licensed or go to the cath lab. So first case, we've got a 54-year-old female. She's diabetic, says she was awakened 30 minutes before you got there with some nausea and diaphoresis. First responders on scene said blood pressure is 180 over 60, respirations in the 20s, heart rate is 68. She's sat in 96%. I always recommend a glucose, gives you a lot of information. If it reads low, I can fix it, right? If it reads high, I know we got a problem. Everything else in the middle really doesn't matter to me, all right? So what do you do? So if you think about acute coronary syndrome, our protocols were initially written that said chest pain, and now we've added or suspected ACS. So a diabetic that has nausea, vomiting, shortness of breath, sweaty, diaphoretic, that's concerning for a big heart attack, right? Big heart event. It's not just chest pain. So chest pain is a classical definition of having a, quote, heart attack. When you think about how you get to be put in a textbook as being classical, if you're 25% of the population that have that symptom, you're classical. So if 25% of the people have chest pain with a heart attack, that tells you what? 75% do not. So you cannot go by that. So suspected ACS, these guys can get a 12 lead pretty quick, okay? What else are we gonna do? We get a relative history and physical on these folks. So when I went back to med school, I learned that you take a history on somebody, you do a physical, then you step out, you think for a few minutes, and you go back and you act with them. And that's not the way we practice. We're getting our history as we're doing our physical, making a decision what we're going to do. So I say, this lady, I'm going to go in, my hand's going to be on her real quick. Is she warm? Is she dry? Does she have a radial pulse that's palpable? Okay. If so, I'm working on my vital signs. I'm hooking up to a 12 lead. Somebody's going to start an IV and get an AccuCheck. And I'm asking questions. All right. And you don't have to be fancy with the questions. The goal of getting a history on somebody is to risk stratify. Are they at high risk for having a bad outcome, right? So 53-year-old, are you a diabetic? She says yes. I say, do you take shots or pills? All right, if they're taking shots, that means they're probably a type 1. They're higher risk for coronary syndromes, other issues. If they take pills, probably a type 2, probably less risk. I'm still concerned, but I'm not as concerned. And that kind of puts in my mind, how fast am I gonna get this 12 lead? How fast am I gonna do my exam? What do I need to do first? Does that make sense? All right, I had coffee, I'm talking fast. It's good, sweet. All right, so other things I'm asked, have you ever had a heart attack or a stroke? If they say yes, I know they're high risk for having other ones, right? All right, so we got our exam. When you think about vital signs, respiratory rate, the number to me is not super important within reason. I'm looking at work of breathing. So if I'm looking at somebody and I take a whole minute to count respirations, it's probably not going to give me a lot of information, all right? So I'm looking at them. Are they accessory muscle use? Are they working hard? Then I'm concerned. If I'm counting for a respiratory rate, is my hand is on the pulse and I'm feeling, is it too fast or too slow? I'm watching them breathe. If they breathe more than 2 times in 6 seconds, how fast are they breathing? 20 times or more a minute, right? I'm done. I'm not going to sit there and say, is it 22 or 26? It doesn't matter. The tachypnic, I call it a day. So she's diaphoretic, shortness of breath, nausea, right? She's tachypnic, right? I'm getting a 12 lead on this person. Have y'all seen this yet? Instead of where's Waldo, this is where's, what's the guy's name that's going all over the internet now in the chair? Bernie. I can't say it, I'll get in trouble, right? Yeah. So it's where's Bernie? He's in there. Kind of funny. So this is her 12 lead. Is the rate too fast, too slow, or okay-ish? Man, nobody's going to talk. It's not like firemen. It's okay-ish, right? So machine says it's 100. I'm going to do my box method. So it's 300, 150, 100. Yeah, around 100-ish. 98 to 105 doesn't really matter. It's not less than 60 or 50. It's not more than 140. Rate's okay-ish. I'm going to look at injury patterns. I'm looking at leads 1 in AVL. Not super scary. That's a little concerning, right? That's ST elevation. It makes me uncomfortable, all right? I'm going to look lateral. I'm going to look at 5 and 6. Those look reasonable. I come back, I look at inferiorly 2, 3 in AVF. Now I got depression, so it's not a STEMI, but that makes me think, okay, maybe there's some kind of heart damage going on somewhere else. And I already saw that. So now my radar is going off. Diabetic chick, breathing fast, sweaty, with the EKG that's already abnormal. So now I'm like, all right, let's go and get that IV started. All right. I look V1 through V4, maybe a hint there, but nothing super scary. I'm looking for elevation or depression. Then I go back and look at AVR. I don't see anything. The next thing I'm gonna do, and I do this the same way every time so that when I've been up too long and I'm tired, I don't miss something. All right. Now I'm gonna go back, I'm gonna look at intervals. P interval looks fine. QRS is reasonable, okay? My QT interval, important if somebody has long QT, we'll talk about on another day, but QT interval looks fine as well. And then if I put the EKG down, I'm gonna do one more time. I'm gonna look at 1, AVL, 5 and 6, 2, 3 in AVF, V1 through V4, and AVR. So it's always the same pattern over and over. So that way when I'm really tired or my coffee's not in me, I'm not gonna miss something. So EKG is concerning, but not a STEMI, right? All right, so what are we gonna do for this chick? Can't say chick. What are we gonna do for this patient? Yeah, so I think fluids are reasonable. She's tachycardic, she's nauseous. IV access fluid seems very reasonable. She's a diabetic, she's probably volume down a little bit, all right? People have talked about other things like the FONA, the MONA mnemonics. I know what MONA stands for. Remember that from medic school a long time ago? Yeah, morphine, oxygen, nitro, aspirin, and you kind of work your way backwards. Some people switched over and said FONA using fentanyl as well. But I would say that fluids are reasonable. I would say that she also needs an aspirin at this point in the game, right? Remember, aspirins jack up platelets. So if this is her coronary artery and she was having a big heart attack, okay, the platelets will go to this place and make it bigger. If I give her an aspirin, it's going to block off some of the ways that the platelets attach to each other. So now they kind of float downstream. Okay? So aspirin is very important. What are the contraindications to aspirin? Why would you not give this person aspirin? Yeah, so maybe ulcers, previous bleeding problems, all right? So, yeah, well, yeah, I don't do that. I don't trust my patients. So if they say they took an aspirin, it's probably a Tylenol, maybe a Norco, a little bit of meth. You never know what they took, right? So if you guys give somebody an aspirin, I'm not going to repeat it in the hospital because you guys are sharp. Patients I don't trust, right? Right? So I would say aspirin is the first drug, okay? She's a little bit hypertensive, having chest pain. Nitro is reasonable. Remember, nitro will lower the blood pressure. I don't give nitros to patients having chest pain to have IV access, all right? Obviously, when you think about risk stratification, what drug do you ask before you give nitro? She's probably not taking it. Yeah, are you on Viagra, something like that? We can bottom your pressure out. She's probably not on it. Who knows? But always ask. And I tell the guys when I'm asking this question, I don't like yell it out in front of the crowd on scene. They're not going to say yes. I say, hey man, what are you taking? These medicines can hurt you. And I just tell them the way it is. Are you taking something to help you? You know, that way you get your answer. Even if they don't tell you and you give them nitro and the pressure goes to 80 over 40, they look like dirt. What do you do to fix that? You give them some fluids. So we have a way to fix that. Right. Oxygen, she's not super hypoxic. You can argue she's tachypnic. She needs a little O2. All right. So I'm fine with that as well. And then morphine. How does morphine help the heart? Yeah, so morphine dilates this vessel. So if it is having a heart problem, you drop the blood pressure, this dilates, a little bit blood flow. In reality, it takes somebody from saying, oh man, my chest is hurting, to them like, yeah, my chest hurts, but I'm high, I don't care, right? So plus it's America, we give morphine a lot, right? Fentanyl's out there. Some folks are using fentanyl. I really don't see any use for fentanyl in cardiac chest pain. It's not going to hurt the patient. You won't drop the blood pressure. There's really no benefits. Some people have talked about using ketamine. Are y'all using ketamine down here for pain? Yeah. I would not use ketamine in these folks that you're concerned about ACS. It's going to increase the heart rate, increase the blood pressure. I would avoid ketamine in these folks, but morphine is reasonable. And then the last thing I'm going to do for this lady is I'm going to do this. It's kind of an inappropriate joke. If you've watched me online, you've seen it before. I'm going to do serial EKGs, right? So, yeah, I know. Thanks, Chief. Yeah. There's no risk to a 12 lead. If one 12 lead says STEMI, there's no reason to do another one. You're done, right? You got all the data you need. You bring me a STEMI 12 lead, they're going to go to the cath lab no matter if it changes on me. If they don't have a STEMI, keep hitting it. Take care of the patient, but every few minutes, print another one out. You may get lucky, they may get unlucky, and you see a STEMI. But now you know what's going on with the patient. Now you get the appropriate care for these folks. So this is our second EKG. I would say 1 is more concerning. We already knew we were up in AVL. I look over here at 5 and 6, and now I got what? ST elevation. So now she is STEMI'd out, right? So in my mind, I'm still going to look 2, 3 in AVF. I'm V1 through V4. I'm not looking as thorough because I've already got my diagnosis, right? So now she's a STEMI. So now what changes? What if she was already said she has ulcers in her stomach, didn't want to take an aspirin? What do you do now with this aspirin? Now she gets it, right? So risk to benefit, if she starts having a GI bleed, we can fix that. Now she gets an aspirin. The only people I don't give aspirin to having STEMIs are people that can't take it because they're being tubed, or they tell me last time I took an aspirin, I swelled up like a bullfrog and they cut my neck. I don't give it to them either. Anybody else gets an aspirin at this point, okay? So, perfect. So aspirin, IV fluids are going, I'm gonna control her pain, and we're gonna take good care of her. So 2 ways to treat this. We can take them to the cath lab and open them up. There's some parts of the state that we give limited access to cath labs, and sometimes you may have somebody in a cath lab and we have no way to get them there. We just don't have enough resources. Those folks, we can give something called a thrombolytic that goes in and takes that clot, breaks it up, and pushes it downstream and buys them time to see a cardiologist. If you look in the back of the protocol, and I know y'all have seen this before, it's a thrombolytic check sheet, right? Y'all fill these out in all your STEMIs? Yeah, me too, right. Thank you for smiling on that one, right? So all I'm saying with this is understand why we do this. So we're looking for people that we can't give thrombolytics to. So if a dude just had cranial surgery, right, just had surgery on his C-spine for some reason for chronic pain, I cannot give him a thrombolytic. He may bleed in that space and die. If he had a recent stroke, a hemorrhagic stroke, I can't give him a thrombolytic. he could bleed in his brain and die. So look over these contraindications and know why. So a lot of reasons you can't do that. I won't go over that today. State says you're supposed to turn this in with the patient when you go. My recommendation is know the information. If you got to put on your glove, that's fine. Tell the physician. STEMI patients report goes from you guys to the doctor. Okay? Nothing against nurses. I was a nurse a long time. But you show a physician a 12 lead that shows STEMI, they're going to get off the chair, go see that patient, because we have metrics we got to make or we get in trouble. Other things to talk about, if they have, well, I'm not going to talk about that today. So what else are we going to do for this patient? They got the aspirin IV fluids, heading to the hospital. Hospital knows you got a STEMI. What else does this person need now? I would say two things. I would say O2. American Heart says no oxygen unless you're hypoxic. There's good data that long-term high-flow O2 is bad for people. I would say an environment that you guys practice is different. If there's one of you guys, do y'all transport here? All right, exciting. Yeah, I saw smiles. Y'all like doing that too, don't you? Yeah. So if you're transporting and there's just one guy in the back or one provider in the back or even two, and you put O2 on this person and they go into cardiac arrest, you can reach up, crank that O2 up to high flow. You got passive oxygenation. You can start your CPR as your buddy pulls over and y'all can manage this patient. So I give O2 to STEMIs is pre-oxygenation before they go into cardiac arrest. I don't call it supplemental. It's pre-oxygenation. Okay. The other thing I throw on my STEMI patients is the defib pads. The things that kill you early in a STEMI is dysrhythmia, VTAC or VFib, or some kind of heart block, right? So again, if it's just you in the back of the truck, you're heading down the road and they go into VFib and you got your pads on, you put your cigarette out, you charge the 200 and you shock them, right? If not, you got to pull over, start CPR, start bagging, so it buys you time. You can't put pads on everybody. Your boss will fire you. They cost money. But STEMIs should get defib pads, all right? And this was a, I think it was in the summer, the date may be on here somewhere. Young guy, chest pain, EKG, rhythm, the rate is okay-ish. You start looking at injury patterns, one in AVL, I go over here and now I get sweaty, right? I'm popping an aspirin because he's making me uncomfortable. Dude's having the big one. EMS popped an aspirin, okay? Normally medical calls, you stay, you evaluate, try to stabilize. STEMIs, you can't fix in the field. It's like trauma. So EMS picked him up, put him in the truck, moving down the road, IV access, nitro, pads on, lo and behold, he goes into VFib. They defibrillate, they got him back. There wasn't no 6-minute wait to do things. It was early defib, made a difference. Guy gets to the hospital, we already saw the EKG, cardiologist is hanging out waiting for us. He goes to the cath lab. Important stuff. There are a lot of things we see in EMS and the ER that is junk, right? I've had knee pain since 1974. My toe hurts, chronic back pain. But occasionally we have something we can intervene on and make a difference. So we can save lives. There are things out there we can fix, and STEMI is one of them. That's why I'm pushing this pretty hard. So back to his EKG. This was the EKG. The second one was pretty bad. This patient gets to the hospital, gets to the cath lab, and these are the cath reports, or just still pictures. I can't make the videos load for some reason. But you can see the squirt dye into the artery, and there's a blockage. They go in, they kind of rotor-root it out, put a balloon in there, put a stent, and now you can see we got great perfusion going through there. So now we got a 52-year-old chick who has chronic health problems, had a big STEMI. Had we missed that? Has she sat on a wall somewhere parked for 45 minutes? Had we not done the appropriate care, she'd either die or she had bad heart failure and can't go back and be productive in society. Now she's good. It's pretty cool. This is an EKG given to me by a medic up in, where's the? Birmingham. And this is somebody in a cath lab. And if you look, that's lead 2 at the top. And see how you got ST changes? Y'all see that? Big ST elevation. That's the wires in. They put the balloon up a little bit and you see the ST change. It goes down. Hang on, let's do it again.
So, hey, Dr. Ferguson, so
yeah.
Why does that happen so instantaneously? Is it about the way the signal can come through the myocardium when it's different? Why? So it's an instant change on the 12 lead.
Right.
There's an insult to the myocardium. Is that right?
There is. And don't make me lie and try to remember pathophysiology from med school because I have to fake it. And I got colleagues that probably know it better than me that are here. But in short, when that is occluded, you can see that ST go up, right? The heart's being damaged, ischemic, hurting. They put that balloon up, blood flow goes through, EKG looks better. So it's pretty cool. I can't make it play again. So this is the second case. It's a 48-year-old male with chest pain and shortness of breath after eating at the Waffle House. We've all been there, right? I like the Waffle House. First responders say his heart rate is 40, respirations are 20-ish. Remember, I'm not going to spend all day counting those things. I'm going to look, is it too fast? Blood pressure is 80 by palpation. Glucose is 288. So is he sick or not sick? Sick, right? Super sick, right? That's his 12 lead. One of the questions I would say is, why did you get a 12 lead before you manage the patient? But we'll take the 12 lead, right? So too fast, too slow, or okay. I would say it's too slow. Just looking at it, and plus the report, hands on the patient, he's diaphoretic, he's hypotensive. If I count boxes, 300, 150, 175, I forgot, way too slow, right? Way too slow. Quick purview that leads, depression here, I'm getting concerned, looks reasonable. 2-3 and AVF is up, so he's having a STEMI, so I'm done. 12 lead goes down, we're on the phone, med control to figure out where we need to go if you have more than one option in your area, all right? If not, we're gonna do the same kind of care we talked about earlier. If they're able to talk to you, I'm popping the aspirin in them. I don't really care about a history as much because a history kind of risk stratifies this patient. Do you have a chance of having a heart attack? I know she's having one, right? So I don't care if she's had one before. I do want to know about medications. Are you on blood thinners, things like that to screen out for thrombolytics, all right? And then we talked about other medicines that are important to ask. So I would say he's too slow. When I say a too slow rhythm, I think three things. I think it's a drug overdose, intentional or unintentional, like a calcium channel blocker or beta blocker. I think electrolytes or hyperkalemia, or I think ischemia. Now, other things cause bradycardia, but you picked that up in a primary exam, right? So dude shot in the belly, talking to you, heart rate of 140, looks like dirt, and he starts bradying down. He's 120, 110, 70, 50. What's happening to him? He's dying. Right, exactly. So he's hypovolemic, all right? So I know what's fixing that. He needs blood products, TXA, and a surgeon, right? The kid who's 6 months old is breathing 3 times a minute that is bradycardic. That's not the problem. The problem is the problem with them is they're hypoxic, right? But for other things you don't pick up in your primary exam, these are the 3 things I think about, right? So our patient's gonna get aspirin, gonna get IV fluids, and then what's a good drug we're gonna give this person right now? Blood pressure of 80, kind of confused. You said it. No, nitro. No, I want to do nitro. I thought you said atropine. You got me excited, man. So I would do atropine, right? So atropine's increase that heart rate, right? So atropine's quick, it's easy, it's old school. I used to do a milligram. If 1 milligram works, I high five my partner and we head to the hospital. If 1 milligram doesn't work, which sometimes it doesn't, not a problem. You can move on down the road. What's another good drug you can give? I hear voices in the dark. I can't see. No, ketamine. God, you're fine. Yes, dopamine. Dopamine's great. So hospitals are going away from dopamine for like sepsis and things like that. But dopamine increases heart rate and blood pressure. That's what this dude needs. So dopamine's quick and easy, right? Y'all carry dopamine? I know some places do not now. They're going just epi. So I love dopamine for that. So dopamine's a great drug. Crap, it wasn't. We'll talk about dopamine in a minute. It wasn't on my next slide. Other things I think about is calcium. So calcium, when you think about the way things work, when you give somebody dopamine, you give them epi, the short version is it improves calcium inside the cardiac rate. So calcium's a reasonable drug to give these folks as well. American Heart doesn't do it anymore. I still do it. And I do it for a couple of reasons. One, I said there's probably no risk, potential benefit. The other thing I think about is that when you think about calcium, calcium fixes one of the causes of bradycardia. So if I'm not sure what's causing it, if they're hyperkalemic, calcium will help fix that. So this is a slow and ride rhythm. The first thing you ask this patient is, excuse me, sir, are you alive, right? That looks horrible. This is hyperkalemia gone wild. Textbooks talk about peak T waves, and that's true. But when you get a wide QRS and a wide P interval, it's hyperkalemia. That one's pretty easy to pick up. This one's not so much easy. So this is somebody with a heart rate in the upper 30s, lower 40s. Injury patterns look fine. All right. And then I go back and look at my intervals, and I really don't see P wave. So is it AFib, kind of slow? Don't know. I look at my QRS. My QRS is greater than 120. So this one I'm going to think hyperkalemia. Calcium may help this person. Now we know what's going on with that chick that person we just saw a few minutes ago, right? Having a big STEMI. So dopamine is a great drug for them. How do you give dopamine? Anybody know? You can't say IV. That's easy. So I'll tell you how I give it. I spike the bag. I prime it. I hook it up to the patient. I open it up. I turn back to the patient. I'm repeating the 12 lead, maybe getting a second IV. About a minute and a half later, I'll look over and cycle the blood pressure, and I'll look at the heart rate. If they're better, the heart rate is now 70 and blood pressure is 110. At that point, I slow it down and I break out my cheat sheet and I set it at 10 mics per kilo per minute. Okay. If it doesn't work after 10 minutes, my partner is going to slow it down. We're going to have somebody else set it to 10 mics, and I'm moving down the road to fix them. This is a titratable drug, but you don't sit there and count drops for the first couple of minutes when somebody's crumping in front of you. Sweet. Kind of inappropriate humor. And then after you do dopamine, the next thing we do is what? We pace them, right? State says pacing is category B, so you got to call med control for that. Hopefully the next SMEC meeting, we're going to change that to category A, but for now you do. So if I was on scene with that bradycardic patient and I got an EMT there and I'm taking care of the patient, I'm gonna say, hey, call med control, get orders for calcium and for pacing. When you call med control, it should be short and sweet. You don't ask us questions, you tell us what you want. We don't want a long story because we get really bored. We have ADHD. So it's, hey doc, 53-year-old fella, STEMI, bradycardic, unresponsive to atropine, dopamine. I'm gonna give calcium and start pacing. See you when we get there. Don't give them a chance to say no. If you call and you tell them, well, I got this 53-year-old guy. He works at Kmart. He's got a Alabama T-shirt on. He's pretty cool. I like the guy, but he's bradycardic, doesn't feel good. And at that point, my mind's already gone to something else. I can't think, right? So when you call med control, tell them what you want, what you really, really want, right? And then if they don't give it to you, reach out to your regional medical director. They can help with some of that stuff too. So I think about ABC's assessment for bradycardia, atropine, calcium, dopamine, then somebody's online with med control. People talk about blocks. In my mind, in the emergent setting, doesn't matter. Somebody with a heart rate of 30 that's hypotensive in a first-degree heart block is just as sick as somebody that's hypotensive with a heart rate of 30 in a third-degree heart block. Okay? If they don't work with atropine, dopamine, I'm get to pacing. Start simple and work your way up. There's a new thing we got now. Are y'all using push-dose epi down here yet? Yes, no? Yes, yes. So push-dose epi just got approved. There's some places that are not carrying dopamine now. They're just doing epi for their vasopressor. So you can throw epi in there instead of dopamine if you want to. I swiped these slides from the training officer out at Springville. So if you're watching, thank you. Short, we know what epi does. Increases heart rate, increases blood pressure, can do bronchoconstriction. So it's great for anaphylaxis. It's great for shock. Really, it's safe as long as you mix it right and give it to the right patient, like any drug. The problem I've seen recently is people are given the 1 to 10,000 epi IV push for bradycardia, and then you take somebody from a heart rate of 30 into VTAC, and it's pretty cool. You get to like shock people and do stuff like that, but it's not good for the patient. So make sure you want to mix this right, okay? And we'll talk about that in the lab this afternoon as well. Either pre-filled saline or draw your own up, squirt 1 ml out so you got 9 mils, drop a cc, a cc of epi, and now you got 1 to 100,000. You label that, and that stays in your pocket or your hand so nobody gets confused and uses it as a flush. And you give a couple of cc's every few minutes, every 3 to 5 minutes to help with their blood pressure and hypotension. So it's like giving an epi drip without having to do the calculations. Another way to mix this stuff up is if you know you're on a scene where you're gonna need this, somebody puts a milligram of epi in a 100 cc bag of saline if you got that, and now you got it, same way. But I would say make sure you practice this, because if you do this at 2 in the morning when you've been on your second 48-hour shift and you're tired, you're gonna make a mistake and hurt somebody.
So Doc, I'm curious, are y'all able to get pre-filled epi 1 to 10,000 in this area consistently? Because we're having trouble in Birmingham. We're only able to get it a lot of times in 1 to 1,000. Right. So to make 1 to 10,000, we're already diluting it with a flush.
Yeah.
So if we're going to go to 1 to 100,000 for push dose, we've either got to do what you said,
Yeah.
put 1 milligram of 1 to 1,000 in a 100 cc bag, or make the 1 to 10,000 and then dilute it twice. It would be a double dilution.
Right. So this is something that you cannot make on the fly in a peri-arrest situation. This is something you should have that plan out, and you should practice it just like anything else you do, so you don't make a mistake. Because it's poor form when you give too much. And I've seen 2 cases in our region where there's been too much epinephrine given. Okay. Okay, so same patient, same EKG, heart rate of 40, except now he's joking with you. He wants to finish his Waffle House burger. Blood pressure is 140/60, respirations are 14. He's sat 98%. What do you do different for this guy? Does he need atropine? No. He's bradycardic, but he's not symptomatic. Doesn't need dopamine. He probably needs a 12 lead to figure out what's going on. I would get IV access on him, and I'd move toward the hospital. And I start asking more questions like, what's your normal heart rate? What's going on? Have you taken any medicines? Get a good history at that point. But I would not treat somebody with a normal blood pressure and mental status with just a heart rate of 40. So this is that guy's cath report pre and post. So he had a right coronary that was jacked up, as you can see here. They go in, balloon it out, and now you got great perfusion. Questions, comments, statements within reason? So this one, too fast, too slow, or okay? I'd say it's okay-ish. I start looking at injury patterns, and I say 1 AVL and lateral makes me uncomfortable, right? 2, 3 and AVF makes me uncomfortable. V1 through V4, I'm still a little bit uncomfortable here. Not a STEMI there. And then AVR. I go by look in intervals. My PR interval is reasonable. My QRS is wide. So now I got to think, is this a left bundle or a right bundle, right? So this is a left bundle because I got no Q wave here. And this kind of points down. Somebody told me once, they think about this as if you have a Y QRS, we know what kind of bundle branch block you got. If you're up in V1, it's like you're turning right. If you're down, it's like you're turning left on an old school indicator, right? So this is a left bundle. What's the machine say? Normal sinus rhythm, left bundle branch block, right? So when you get a left bundle on a 12 lead, a lot of the times the machine's not going to even interpret for ischemia, for STEMIs. But what's going on here? He's having a STEMI. So again, machine is useful, but it's not the end all be all. There's some criteria that we can use called Scarbosa's criteria to look at left bundles to say, is it new or old? Before 2013, a new left bundle in chest pain was considered a heart attack. They went to the cath lab. We don't do that as much anymore, but the short version of Scarbosa is if you have discordance, that's good. So if I'm lead 3 here, I'm QRS is down, T wave is up, not super scary. And this is more than a big box. Discord is good, like in a relationship, right? It's good to fight, right? Concordance is bad. So QRS and T wave in the same direction with elevation, that's a STEMI, okay? And then concordance down in V2 or V3 is also bad. The best way to get good at 12 leads is look at a lot of them. If you do 3 a day per shift, you're never going to learn them. So you got to look at those, train for those, just like you do for everything else. Wave Maven is a good web page. Life in the Fast Lane, like the Eagle song, is another good one. But a quick review of these will actually make a difference in somebody's life one day. So last 12 lead, and this was brought up to me by a department up north that was talking about they're seeing a lot of people come to the station now that want to get well checks, don't want to go to the hospital because of COVID. People were doing it before then, but so they're doing 12 leads and saying, oh, your 12 lead looks good, you can go home, all right? So this 12 lead, too fast, too slow, or okay? Okay-ish, that should be a good one. Yeah, I look injury patterns, 1, AVL, lateral, not scary. 2, 3 in AVF, some artifact, but still not scary. V1 through V4 looks good. AVR is fine. I go back, I look at my intervals, nothing scary. And I look one more time for injury patterns before I put it down. So this guy shows up at the fire station saying he just hasn't felt good in a couple of days. He wants a 12 lead. I look at this and it's like, hey dude, your 12 lead's fine. You can go home, no problem, right? This guy was seeing the ER for weakness and nausea. 12 lead was fine. He waited about 2 hours, finally got back to our room. And as he's talking to one of the docs, they noticed a rhythm change. So what is that? Don't use profanity. Bad. That's the first thing I said, is I said something inappropriate under my breath. Yeah. No, we just take care of it. But yeah. So my point to that is 12 leads are a screening tool. They can pick up madness. Duh. They can pick up STEMIs, pick up hyperkalemia. But a normal EKG does not mean you're not having something really bad happening to you. So yes, people can show up at the fire station, they can get a 12 lead, want a vital signs check, and then want to go home. That's fine. I would recommend to them, if they have health problems, hey, you probably ought to go to the hospital. You can go by your private car. I don't have to take you, right? All the time. All right. And the other thing I want y'all to be aware of is that just because the EKG is normal, people can still have something really bad happen in a few minutes. So dude went from a normal EKG, not feeling good, to I'm dying. Why'd you get a 12 lead? You should be pushing drugs and take care of me. Horrible EKG. Just looking at this, what do you think this is? It's too slow. Way too slow. But what do you think is going on? Drugs, electrolytes, or ischemia? Well, he had a normal EKG 20 minutes earlier, and now I got ST elevation 2 and 3. He's having a big freaking STEMI. Remember, right-sided infarcts would make you slow. I'd also argue that he's probably in heart block, right? But I'm still going to manage him the same way. I'm going to use profanity, right? I'm going to start IV fluids on this dude. He gets one atropine because it's quick, it's simple, it's readily available. If he gets better, I'm happy. He's still sick. If he doesn't get better, somebody's spiking some dopamine or giving me push dose epi. I'm putting the pads on him because it's probably not going to help. I need to get him paced. And I'm thinking about, is he going to need an airway here in a few minutes? And he's fixing the code. I got about 3 minutes to see if I can. So this is a video. We started using video scopes several years ago out at Center Point, and we record them. And it's a great way to kind of do some quality improvement and help folks out. And I won't make you watch this whole thing.
Which one is this, Doc?
This is the slow one. We had multiple attempts.
Oh, yeah. Gotcha.
But I can't seem to make the bottom show up the. All right.
So you're going to show them the other one as well?
Yeah, I will. So the point of the first one was there were multiple attempts at intubating, and a patient had a lot of airway edema. So they had pulmonary edema, a lot of vomitus in the mouth. You can see the scope go in. You see the vomit moving. You know CPR is going well, but you also see a bunch of crap in the oropharynx. You can see the cords. No tube ever goes in until about 8 minutes in. All right. They keep suctioning and stuff. And the point of that is that it should be more like this. This was at a nursing home, a little bit faster. In the mouth, there's vomit. You can tell CPR is going on because the chest is moving. And tube goes in. With video scopes, it makes it a lot easier, right? You can see the hole. Sometimes we get confused and go for it soon enough, right? So if you're using video scopes or if you're not, if you have somebody that has an airway that's full of vomitus, if you put an oral airway in or an eye gel and you ventilate, are you doing a lot of good? Probably not. You're pushing vomit back into the lungs. Point to that being, you're probably better off having 6-8 liters nasal cannula on them, passive oxygenation. Look, when you see it, even there's a lot of vomit in there, put that tube in and secure it. And we're going to practice with some airway stuff and vomit today as well. Not real vomit. Yeah. Questions or comments within reason, and we'll take a 5-minute break afterwards. No comments, no questions. Any questions on the chat box, sir?
Right now, I think we're all called up, Doc.
Okay. We're going to take 5 minutes, and then Dr. Robinett will talk about some.
Got one coming in here. Right-sided infarcts make you slow, quotation marks. Does that mean right-side MIs are more likely to cause bradyarrhythmias?
I would say yes to that. And you also think about, there's some people out there saying that if you have an inferior infarct or right ventricular infarct, that you don't give nitro to those people because they're more prone to being hypotensive. And in theory, that's reality. But I would say if I have a person having an inferior right-sided infarct and the blood pressure is 180/60 and they're having chest pain, they get a nitro. If they're having a true right-sided infarct and their heart rate is 40, they probably don't need nitro to begin with. If their heart rate is 40, I'd argue the blood pressure is probably less than 100, so they don't need nitro, right? I'd also argue that if you can give nitro to a patient having a STEMI, they have IV access first. The people that don't put an IV in before I give nitro to is the people like a dialysis patient who is full of fluid. They missed dialysis for 3 days because they're out smoking crack with their family, right? I shouldn't say that, it's mean. But they're volume overloaded, pulmonary edema, blood pressure 220/120, and it's a dialysis patient, you can't get a line in, I'm going to pop nitro on them pretty quick and then put them on CPAP to fix their respiratory problem because I'm not going to drop their blood pressure down so low they have a bad outcome. Does that make sense? Okay. Well, forgive my inappropriate humor. Appreciate all you guys do. Thank you for Foley having us down here. I'm going to thank the region, Garmin as well, for letting us come down, and see you in 5 minutes.
Associate Professor of Emergency Medicine at UAB. I'm the medical director for the City of Hoover's Fire Department. And I'm also the program director of the new Physician EMS training program at UAB as well. What I'm going to talk about today is what I call the fourth trimester, because everybody talks about, you know, what trimester are you? Where are you in pregnancy? 1, 2, and 3. We're going to talk about the fourth trimester because there's a lot of postpartum complications that happen after the baby is born, okay? And these can happen anywhere from 3 up to 6 months postpartum. All right, so what we're gonna do today, my simple goal is we're gonna talk about our differential diagnosis in a postpartum patient. This actually comes from a personal case I have that we'll talk about, that we maybe sort of had a delayed diagnosis because it really wasn't on our radar. We're gonna talk about life-threatening complications to the mother after delivery, okay? We'll talk about workup, we'll talk about management. A lot of it can be solved with diesel, maybe some of it supportive care, and we'll take a look at specific cases. I'm talking about postpartum hemorrhage, depression, the baby blues, endometritis, thyroiditis. We're going to talk about preeclampsia and eclampsia, which can still happen after the baby is delivered. We're going to talk about peripartum cardiomyopathy and then thromboembolic disease. Now, why is this important? This is the rates of maternal mortality in the U.S. per 100,000 live births every year. We're going in the wrong directions. We're having more maternal deaths after birth than we had 20 years ago, 30 years ago. We're actually going in the wrong direction with pregnancy-related death. We can even break it down even more. We can look what's the causes. Are we looking at hemorrhage, infection, hypertension disorders, and break it up according to, you know, over 3, 5, 10-year periods. The blue there is the most recent time frame I have. We're doing worse, right? We're not doing great. We're gonna go ahead and start with our first case. You get the call. You get a 32-year-old female. She's been home. She's 4 days postpartum, no problems. Everything was going okay. It's a little bit of bleeding initially post-delivery. Seems to be getting worse. She got up to go to the bathroom, had a syncopal event. Husband called 911. You get on scene, you look at her. She looks sick. She's pale, she's cool, she's clammy. Get your vital signs. 86/50, tachycardic, little tachypnic. Sats are okay. All right. So we have to think, what is postpartum hemorrhage? It's the leading cause of maternal death worldwide. Leading cause of maternal death. How do we define it? So we think about greater than 500 cc's of blood loss. It can be a little complicated in the pregnant patient because their plasma volume increases. They have higher circulating volumes. And we got to think about the 4 T's of postpartum hemorrhage. So is it tone? Is it trauma? Is it retained tissue? Or is it says thrombin or clotting disorders? So there's your 4 T's to think about. So what do I mean by tone? So it's lack of uterine tone, also called uterine atony, A-T-O-N-Y, uterine atony. 1 in 20 deliveries will have some degree of loss of tone. You know, risk factors are prolonged labor, having multiple pregnancies, multiple gravid uterus, having very large children stretches the uterus more. Advanced maternal age is a risk factor for this as well. Trauma, we think about lacerations, uterine inversion, uterine rupture. Usually happens immediately postpartum, but you can have a delayed laceration that wasn't repaired, didn't heal properly. Retained placenta is an issue. People doing home births, water births, maybe something was missed in the hospital, or an invasive placenta. This is where the placenta actually burrows into the uterine wall. And even though you deliver the placenta afterwards, there can still be some retained or invasive placenta left. And then again, coagulation disorders. Think about DIC, hemophilia. Is it sepsis? Can they have some sort of bleeding disorder, making it more likely to have postpartum hemorrhage? So in pregnancy, the circulating plasma volume increases by up to 50%. So you may have a dilutional, you think about your hematocrit may be a little bit lower than normal. There's extra plasma, have an extra 1,250 cc's, let's say roughly, of plasma. So when you think about that extra circulating volume, your body's trying to return to normal afterwards. You're having that hemorrhage, so it can affect your normal hemodynamics as well. So it's just something to keep in mind if you're going to have postpartum hemorrhage and you're looking for that greater than 500 cc's of blood loss. So what are we going to think about treatment? So fundal massage. This doesn't require anything fancy but a pair of hands. And it is literally pushing on the uterus. It is uncomfortable. It is not pleasant, but you can actually physically massage the top of the uterus through the abdominal wall. And actually that by itself will increase some of the tone and slow bleeding. If they're hypotensive, what are we going to do? We're going to put that large bore IV in. We're going to start some fluid replacement. Oxygen, yeah, might make them feel better. They're clammy, they're diaphoretic, a little bit of oxygen, a little relief of the tachypnea, that air hunger they're feeling because they're feeling sick. I say question mark TXA. What do we use TXA for now? We got a great protocol for use in trauma. Some places worldwide, TXA has been approved for postpartum bleeding, abnormal uterine bleeding. It's a cheap drug used all over the world, orally, IV, topically, whatever. Maybe used in the hospital. It's not approved for pre-hospital care, but it's something you think about on your radar that, you know, somebody who's hemorrhaging, maybe it's trauma related, uterine atony related, that TXA might be on the differential when you get to the hospital. I mentioned postpartum depression because to me, this is one of the ones that's sort of scary because we tend to blow it off. There's a whole spectrum of illness with postpartum depression. You can get the baby blues, fairly normal, many people have that. Can progress to postpartum depression, and actually have an entity called postpartum psychosis. This is the most common complication after delivery. The most common cause of death after delivery worldwide is hemorrhage. The most common complication, postpartum depression. So, talk about the baby blues. Common, transient, sadness, weeping, irritability, anxiety, maybe some mild confusion. Occurs in somewhere wide range, 40 to 80% postpartum women. Symptoms peak 4th to 5th day of postpartum, right when you're going home, right when you're getting no sleep. Resolves 10 days, 14 days. Now it can progress. Approximately 13% of women postpartum will have full depression. Recurs in 25% of patients that have a history of depression. And it begins roughly 4 weeks after delivery. So this is a little longer than just the baby blues. That's resolves, you're getting into your groove, things seem to be going well. This 4-week time period, the way we do it here, right, in our society is partners going back to work, family support's dwindling off, you're a month, you're in the groove, then you start having more severe depressive symptoms. Why does it happen? Multifactorial. A bunch of things can happen. Rapid decline in hormone, genetic susceptibility, life stressors, everything's going on. Who's at risk? Well, we know there's some risk factors, right? So is there a history of depression? Is there a family history of mood disorders? Are you having other stressful life events that happen at the same time? So it looks like other patterns of depressive episodes. So you have depressed mood, you can have anxiety, loss of appetite, sleep disturbances. There's overwhelming sense of fatigue, more than just your sleep disturbance. There's guilt that you're not doing enough, that you can't be enough. You're having problems concentrating and completing your normal task. To be diagnosed, it has to be present for most days, every day, over a 2-week period. There's a bunch of these screening scales that I don't know if they're useful or not, but you have to think about other causes of fatigue as well. There are anemias, or thyroid disease, is there other causes? Most of the times, these patients will get antidepressants, first line SSR, first line, starting at a lower dose and then titrate up. These patients will respond to psychotherapy and counseling. There may be a role in hormonal therapy in the future. We don't really know, but there are resources available to help our patients. On the far extreme is postpartum psychosis. Now, this is a psychiatric emergency. These are patients that are having thoughts about killing themselves or killing their infant. This is postpartum depression taken to the extreme. This is a medical psychiatric emergency. You may have bizarre behavior, disorganized thought, delusions, hallucinations. Usually within that first 2 weeks of the postpartum period, right after delivery, this may occur. This is an emergency. These patients come to the hospital, they need to come to the ER, they don't need to leave AMA, they need to be seen by psychiatry, they need to be admitted. This is a life-threatening condition. I'm going to transition a little bit over to endometritis, postpartum infection. So this is an infection of the uterine lining. It's not that common. Less than 3% of vaginal deliveries, somewhere between 50 to 30% of cesarean deliveries, you can have some size of infection. So risk factors, somebody had prolonged labor, prolonged rupture of membranes, requiring multiple exams during the peripartum period. They've had to have internal monitors placed. Maternal diabetes, meconium before delivery, are having to require manual removal of the placenta. We've introduced a foreign body. So how does it present? Usually within the first week postpartum. So this is, they're already at home. They're transitioning. That's when you guys get called. They start having high fevers, abdominal pain, pelvic pain, foul lochia, foul smelling discharge. They have a high white count in exam, and they're usually bacteremic, okay? So these patients actually look septic is what we're describing here, right? So they're fever, they're tachycardic, they're hypotensive, and this is all from a postpartum complication. It's usually a polymicrobial, ascending infection. It's a mixture of multiple different organisms. If they have a history of group B strep, which they screen for before delivery, you're at an increased risk of endometritis. So what do we do in the hospital? We check labs, right? We get our CBC, see if they have a white count. We get our blood cultures. We get our urine cultures to look for other causes. We check for gonorrhea. We check for chlamydia. Is there a role of imaging studies in the hospital? Sort of unclear. Some people will get an ultrasound, some people won't. Say it's more of a clinical diagnosis. All right. Then we start antibiotics. We know that if they're not getting better, then we need to pursue and say, well, was there a uterine rupture? Is there an abscess formation? Is there something else going on that they're causing them to become septic? We give broad spectrum antibiotics, 28, 48 hours stabilized, maybe add some other ampicillin before they can go home. Postpartum thyroiditis. So this is a variant of Hashimoto's thyroiditis. So this is sort of interesting that it can occur within 1 year postpartum. So even though you're talking about the 4th trimester, we're still talking about something pregnancy related happening up to 1 year after delivery. Somewhere between 3 to 16% of postpartum. I feel like that's a little high. If you have diabetes, you're at an increased risk of thyroiditis. So initially they look hyperthyroidism, lasting a couple of months. Then they get hypothyroidism, but it's real variable. So they can get hyperthyroid only, they get tachycardic, fevers, flushing, weight loss, and then they go hypothyroid. They can have one or the other, with the hypothyroidism, with lethargy, weight loss, hair loss, either way. Sometimes it's hard to figure out. Be real mild, real variable presentation. So these are all the symptoms you may have, right? So you're having hair loss. Well, that can happen normal postpartum. Depression, anxiety. Well, that can happen as a part of the baby blues. Decreased milk production, overwhelming fatigue, and then maybe a goiter. That's why some of this, there's a lot of overlap, and it's real subtle and hard to sort of tease out the differences. So you may see a small goiter on exam. We have to get this very specific anti-peroxidase antibody, which helps diagnosis. Otherwise, we think about checking thyroid panels. Most people don't need treatment if their symptoms are mild enough. If they're bothersome, we can start them on thyroid supplementation. The key is you have a new child at home too. So if you're breastfeeding, you have to take into effect, are some of the medications we're going to start across the milk barrier and be excreted into the infant at home. Change gears a little bit and give you another case. Okay, 38-year-old female, bad headache, blurred vision. You get there and their blood pressure is this, 186 over 112. Heart rate's 98, otherwise 100% on room air. What do we think about when we think preeclampsia? It's like we hear it and we think this is a complication while you're pregnant. So you have to be new hypertension, meaning you don't have a history of it. You have to have edema or greater than 5-pound weight gained in 1 week. You have to have protein in the urine. All right. And then what makes it to go from preeclampsia to eclampsia? You start having a seizure. All right. So the traditional treatment for this is, what do we think about? So somewhere between 20th week of gestation up to 6 weeks postpartum, we can have it. They usually come in, I'm having this horrible headache. I'm having vision changes. I'm swollen everywhere. I'm having belly pain. And then they start seizing. It's one of those things you never forget the first patient you see. You know, when I was a resident, I get called, oh, there's somebody seizing in the waiting room. They drag her in there and we know nothing about the woman. We look up and we're like, and she's pregnant. Sort of a dramatic, disturbing, like completely changes the way you think about what's going on. So the things we think about affecting it. So we get proteinuria, you can get kidney damage from the high blood pressure. You can have something called HELP syndrome. You get hepatic failure and low platelets, hypertension, edema, vision changes, belly pain, nausea, vomiting, headache. So 10% of pregnancy, we don't know how many happen postpartum. Risk factors are pre-existing hypertension, diabetes, or autoimmune disease like lupus. So what do we need to do? We need aggressive blood pressure treatment. Magnesium, they're seizing now. Treatment for seizures in the pregnant lady who doesn't have a seizure disorder. You have to think eclampsia. Treatment's magnesium. Ultimately, if they're still pregnant, the definitive treatment is delivering the child. So now they're postpartum. Can't just deliver the child. So we have to be more aggressive with treating blood pressure and treating the seizures. There's a role for labetalol in controlling the blood pressure. Maybe some hydralazine, blood pressure control. This is a little bit longer case I'm going to go over, and this is the one that I was involved in. I got brought in sort of late in the case, and it was sort of a delayed diagnosis. It's a young female. She's like 20, 22, somewhere 19, 22-year-old. It's her second pregnancy. She delivered no problem. 4 days afterwards, she started having worsening shortness of breath. She's like, I'm short of the breath during the day. I'm dyspneic on exertion. I feel bad climbing stairs. No fever, no chill. She's coughing, but not really bringing up anything. All right. So no history of asthma. No history of pulmonary embolus, blood clotting disorder that we know of. No heart disease. No family history that we know of. She's a smoker. All right, so maybe we're wheezing. Maybe she's wheezing because she smokes. No alcohol, no drug, nothing really else. No chest pain, no real lower extremity edema. You know, what's going on? So we looked at her, and her blood pressure is 156/103. It's tachycardic. She's 94% on room air, but she's breathing 40 times a minute. She's working hard to breathe. She's obese. She looks sick. She's sitting up. She's tripoding. She can only speak in like 2-3 word sentences at a time. Everything else is okay, right? So she's tachycardic. Don't really care. She's sort of wheezy, crackly. It's hard to hear. She's breathing real fast. Sort of an obese lady. So this is her chest x-ray, and it just looks horrible. So there's stuff everywhere. Her lungs aren't clear. There's fluid, edema, consolidation just everywhere on this patient. So she got a long workup. She got a bunch of nebs. She got treated for asthma, didn't get any better. She got a CAT scan. Her D-dimer looking at blood clots was high, right? Heart failure markers were high. Her troponin looking at heart damage was normal, right? But her EKG was just sinus tach, she's tacking away, no real ST changes. We're like, okay, maybe she's not having a heart attack, that's good. She got a CAT scan of her chest because we're like, well, her D-dimer is high, she's not getting better with asthma, maybe she's got a blood clot. She's got fluid everywhere, but no blood clots. So what do we do? All right, now she gets worse. So now she's getting 100% non-rebreather, she's getting intubated. Has anybody ever tried to intubate a gravid, pregnant, or immediately postpartum? It's not easy. Their abdomen's still large, their uterus is still large, their lungs are small, they're obese. It was not an easy intubation. Finally get her tube, she gets started on nitro drip, she gets morphine, she gets laces, she go to the cardiac care unit. All right, so now we figure out she's got postpartum cardiomyopathy. Here's a 20-year-old girl who has a ejection fraction of 20%. She now has congestive heart failure. 2 days later, she gets off the vent, she gets extubated, we get a repeat echo, still bad. Her EF is now 30 to 35%. So now she's 20 years with a diagnosis of pericardium cardiomyopathy. She's going to have CHF for the rest of her life. So, rare cause, heart failure in the late pregnancy, immediately postpartum period. This was the case that got me thinking about, man, what am I missing in these postpartum patients? Because this was such a dramatic case to me of otherwise healthy 20-year-old who now has CHF for the rest of her life. So how do we define it? Development of heart failure at the last month of pregnancy within 5 months after delivery. Can't find a definitive cause. No history of heart failure. And they have to have on a bedside echo a reduced ejection fraction of less than 45%. Wide range of the incidents. You know, what do we know? There's a hormonal component, there's an inflammatory component, maybe there's a myocarditis inflammation component, there's a genetic component. Still don't truly understand who gets this and who doesn't. There's risk factors, advanced maternal age, so older than 30, multiple pregnancies, multiple fetuses, African descent, and there's actually a correlation with a being of Haitian descent as well. A history of pregnancy-induced hypertension could be just related to damages to the heart from uncontrolled hypertension. Cocaine abuse, and then oral tocolytics, or people that have preterm labor that they give medicines to stop the contractions. There may be an association with that. You know, we got probable risk factors, we got proposed risk factors, we have emerging risk factors. The bottom line is, it could be none of these, it could be all of these. We still don't truly know. Right, so it can be subtle. This one was like, oh, it's fatigue, dyspnea. She had no lower extremity edema. As a smoker, maybe it was asthma, got treated for asthma. You know, all of these things we're talking about, fatigue, shortness of breath, edema, that can all be normal as a part of pregnancy. What did we do? We looked at an EKG, we looked at a chest x-ray. You know, we can get viral bacterial cultures. They're not really that useful in the workup. So how do we treat it? We treat it like CHF. So this patient got nitro, got started on a nitro drip. We were probably so delayed in getting to that diagnosis, we missed the opportunity to put her on CPAP or BiPAP and avoid intubation. We weren't aggressive with Lasix up front. I have a 20-year-old who's never been on Lasix. How much should we give? 20, 40, 60? What are we going to do here? So there's some studies that maybe we can eventually treat people with IVIG in the future. These patients can go on and get heart transplants from having such severe CHF. And the recommendation is to avoid future pregnancy. There's a question.
Hey, Doc. Yeah, we got a couple. I'll try to catch us up a little bit here. So, first of all, is this the same as what might be described as postpartum pulmonary edema? Are we talking about the same thing?
Yes.
Okay. And we've noticed that you didn't necessarily list acute hypertension. Do these patients usually present as being acutely hypertensive?
Yes, they do. That's part of it. I didn't list it on here, but it's part of the whole CHF presentation with hypertension, tachypnea, low sats, hypoxia.
And is CPAP effective with these
Yes.
patients? Okay.
Yes. And that's why I say we were so delayed in our presentation, in our getting to the diagnosis of this case, we sort of missed the boat. That she was to the point where she was deteriorating and we ended up intubating her. But CPAP is 100% yes, use it, it's effective. She said she was obese. What can I tell you? She was probably 250, 300 pounds. Like,
catching up with the edema.
Yeah.
You're falling behind because we're looking for long-term surgical.
absolutely.
So, hey, Doc, we're a little bit past it, but we also had another question regarding postpartum bleeding and TXA. So I'll just read you what was sent in. So in the absence of trauma and oxytocin not really available in ground EMS, why not TXA after all other methods have been exhausted? And a conversation with medical control. It's not listed as an indication for this particular patient population? Question mark. And just curious if there's different practice with regards to TXA among other healthcare systems.
Yeah, I put the question mark TXA on there because it's not indicated in the current state of Alabama protocols. It's indicated for trauma. This isn't directly trauma related. This is a postpartum. That's why I didn't go into it and just mentioned it. There is variability across the U.S. and across the world where TXA may be on a treatment algorithm, but for the state of Alabama, it is not listed.
Excellent. So any thoughts on what the controversy is or why TXA would be contraindicated?
No. I mean, the short answer is no.
Yeah, great.
The long answer is TXA has been around for somewhere between 60 to 70 years, has been studied in multiple different settings, has been used for menorrhagia and abnormal uterine bleeding. It's available in a PO form that's used in Europe for people with dysfunctional uterine bleeding. It's just not there yet. We just haven't added it as a indication to the state of Alabama protocols. I'm not saying we're not going to be there in a couple of years, but it's not there yet.
Thanks. I think that's what we were looking for, is to find out if you had an opinion on why it wasn't included or if there was some glaring contraindication.
There's not a specific contraindication that I know of. All right. So we're going to wrap up and talk a little about embolism. So there's a 30-year-old with chest pain. Sort of presents sort of classically, like I'm having pain with deep inspiration. They've got unilateral leg swelling. They're dyspneic. Tachycardic 130. Blood pressure looks okay. Hypoxic 83% on room air. So we know that postpartum patients are higher risk for venous thromboembolus. So there's a hormonal induced decreased venous capacitance. You get mechanical obstruction just from the fetus blocking the inferior vena cava. So blood flow is not moving as much from your lower extremities. And you have increased concentrations of clotting factors. So during pregnancy, your incidence of DVT, your risk for it, can increase 4 to 5 times. Your immediate postpartum phase can increase 20 times. Highest during the first week immediately postpartum. Overall prevalence, somewhere 2 to 1,000 deliveries. We still see maternal deaths from this, just over 1 per 100,000. Second leading cause of pregnant female death in the U.S. So what do we know? If you've had blood clots before, you're at risk for getting blood clots in the future, right? There's other risk factors. So if you have a protein C deficiency, protein S deficiency, you're known to have some hypercoagulable disorder, that puts you at greater risk. History of heart disease, history of autoimmune disorders such as lupus. History of diabetes also increases your risk. Multiple gestations. And having a surgical procedure during pregnancy, including C-sections. There's a degree of immobilization that increases your risk. So we talk about all aspects of care in the PTE, VTE patient. You get, what's your baseline risk? What's your pregnancy-related risk? And then, should we be giving prophylactic treatment in the hospital? Do we need a treatment? How are we going to treat it? It gets real complicated because some of the newer drugs that we're using for people with DVTs, PTEs are not studied in pregnancy, not safe in pregnancy. So what are we doing now? So these clots tend to be larger. So there's, in a general population, a subset of patients with blood clots in their legs or their lungs that you can discharge home. You can start them on medicine, discharge them home. These clots tend to be large. So you get admitted to the hospital. We start IV heparin because we don't have all the newer oral anticoagulants haven't been studied in pregnancy, haven't been studied postpartum. So we're still putting people on IV heparin drips. We're transitioning to Coumadin to go home with. Same reason. All right. It was a whole lot, right? 4th trimester of pregnancy complications. I'll just open it up. If anybody else has any other questions.
So we had one come in. How prevalent is pulmonary embolism postpartum? And is that something that we should suspect for any postpartum patient with difficulty breathing? And are there any EKG clues that we could pick up on there?
Yeah, so it's I don't remember the total incidence I had right there, but yes, chest pain postpartum, it absolutely should be on your differential. What do we think? We think tachycardia, pleuritic chest pain. In EKG, the most common, we always talk about having a S1 Q3 T3 in the setting of a PE. Yeah, that's great, but it's not sensitive. The most common thing you're going to see is just sinus tachycardia.
Great, thank you. Does anybody here have any questions for Dr. Robinett? Nope. All right. Well, if you think of any, you can certainly relay them up. If you come back to the skills session this afternoon from 1 to 3, I think Dr. Robinett will still be around, and we'll have Dr. Eversole and Dr. Ferguson here. We had an earlier question about giving atropine or going straight to pacing for bradycardic patients with certain types of MI, and the answer from Dr. Ferguson, if you didn't see it in the chat, was to go ahead and give the atropine first before you pace them. Is that right, Doc?
Unfortunately, we're also going to have to get med control to do the Cat B stuff anyway. So risk to benefit, I'll do the atropine. Remember, if they're not symptomatic, they're not hypotensive, not altered, and they're having a STEMI in the bradycardic, don't give them any atropine, because that's going to increase the heart rate, increase the workload of the heart, can make the infarct bigger. But if they're hypotensive and not perfusing, you're kind of hosed. You have to increase the heart rate or the heart itself will die, right? So it's a risk to benefit on that case. The other thing I want to mention, and I may have missed part of it, talking about TXA, remember, any drug that we have that's on your formulary that you can give, even if it's not an indication that's in our protocols, if that patient needs that drug and you know that and recognize that, you can always call med control. Magnesium, we used to use magnesium just for torsades, right? Now we can use it for respiratory problems in our protocols. But before we change that protocols, medics will call in and say, hey, I got a 30-year-old asthmatic who's hypoxic, not getting better with O2, nebs, IM epi. I'm going to give her some magnesium. And would say, yeah, that's perfect. That's an appropriate drug for that patient. So these drugs can be used for other things that may not be in your protocol. But if you recognize that and it's the right thing for the patient, call med control and tell them. If they say no, when you get to the hospital, figure out why in a nice way, right? And kind of learn from that. That make sense? Yes, no, maybe. I like this microphone. It's like karaoke.
Oh, my word. Okay. Hey, thanks everybody for participating today. Want to make sure that we recognize some people. Thanks to Alabama Fire College for making it possible for us to travel to different parts of the state. Thanks to Chief Darby at Foley Fire for hosting us today, and for the staff here at the Senior Citizens. Been a great venue, and we got a good setup for our skills this afternoon. Thanks to Columbia Southern for bringing out some goodies and helping us out. And Stryker, if you're here today, Stryker will be providing lunch, and they'll be here in just a little while. Chick-fil-A, I think, is on the menu. And then this afternoon, we'll have the skills from 1 p.m. to 3 p.m. Got the 3 docs here, plus Alabama Fire College EMS program staff. And we'll be doing some exciting skills, including maybe some surgical airways, doc. Well, that's right. So if you like playing with vomit right after you eat lunch, this is the place for you today. So anyway, everybody, please remember to fill out an attendance form. If you're here in person, you can scan one of the signs and fill out the form. If you're listening online, the link to the form is in the chat box. If you didn't get that, or for some reason can't get to the chat box, send us an email at Alabama EMS Challenge at gmail.com. You'll get an automated reply that'll have a link to the attendance form. We need 1 attendance form per participant. The password for today's attendance form is trimester. I would have made it 4th mester if I'd had access, Dr. Robinett, to your PowerPoint, but trimester is the password. It's all lowercase, and that'll get you the certificate will be emailed to you automatically. Thanks again, everybody. And if you're here locally, we'll see you at 1 o'clock for skills at the Senior Center in Foley, Alabama.